Now the next one is the acute canaliculitis. What is acute canaliculitis? When there is the inflammation of the canaliculus, this is called, and if it is acute, this is called acute canaliculitis. Okay? Pathogenesis, what is the pathogenesis? Pathogenesis, the most common cause of the acute canaliculitis is the Actinomyces israeli bacteria, which is a gram-positive filamentous bacteria. Anaerobic gram-positive filamentous bacteria is the most common cause of the acute canaliculitis. The sign and symptoms is the canalicular lid will be red and edematous. This canalicular lid margin, if this is the canalicular lid margin, it will be red and edematous. It is mainly a unilateral condition and it mainly affects people over the 40 years. Okay, so the canalicular lid margin will be swollen, red, edematous. It is mostly unilateral and affects people above 40 years of age. Okay, and the punctal, this is the opening. The opening will be pouting. It will the inflammation will push the punctum outside, which is called pout punctum. Okay, so these are the signs and symptoms of the acute canaliculitis. The treatment, we have the medical option and surgical option. And medical options, as this is the acute inflammation, so we will prescribe the patient the systemic and the topical and systemic antibiotics, analgesic, as the condition is very painful because of the acute inflammation, redness, edematous. So analgesic will be advised, and warm compression several times a day is advised to the patient that he should do a warm compression which will resolve the inflammation and will also provide a soothing effect. The surgical options for the acute canaliculitis is the first one is the punctoplasty and canalicular curettage. And punctoplasty, this and canalicular curettage is the gold standard treatment for the acute canaliculitis. Okay? In punctoplasty, what we are doing in punctoplasty, this punctum, we dilate the punctum. Okay? So we dilate the punctum. Both puncti are dilated. This is the punctoplasty. And canalicular curettage, we will compress, and so the pus and the discharge will comes out. So the dilation is called punctoplasty, and the canalicular curettage is the pressing, compression, and the expression of the debris and the pus. This is called the canalicular curettage. So this is the gold standard treatment for the acute canaliculitis. The next one is the canaliculotomy. What are we doing in canaliculotomy? So if this is the lid margin, we will invert the lid margin, and from the conjunctival surface we will get an incision, and after incision we will compress and we will express the debris and the pus from this acute canaliculitis. So this is the canaliculotomy. The gold standard treatment is the punctoplasty and canalicular curettage. Now, acute dacryocystitis. So what is dacryocystitis? Dacryocystitis is when there is the inflammation of the lacrimal sac. This is called dacryocystitis. So if it is acute, this is called acute dacryocystitis. Okay. So what is the pathogenesis? SSP. These bacteria, SSP bacteria, Staphylococcus, Streptococcus, and Pneumococcus. These are the most common organisms which are involved in the inflammation of the lacrimal sac. So, what are the signs and symptoms? The sign and symptoms is that there will be the redness in the medial canthal region in the lower. The medial canthal, and in the lower region there will be swelling and redness. So there will be swelling and redness in the medial canthal and the lower lid region. Okay, because the lacrimal sac is present right over here. So there will be the swelling. There will be the purulent or mucopurulent discharge will be present on the punctum or on the lid margins near the medial canthal region. So there will be mucopurulent or purulent discharge because there is the inflammation and infection. So it will result into the discharge. And regurgitation, remember, regurgitation test shouldn't be performed in acute dacryocystitis. Why? because this is the region, this region has been swollen, red, tender. So this swollen and tender region, also the patient is also in trouble and in pain and in severe pain. So if you perform regurgitation test, it will worsen the condition of the person. So we shouldn't do regurgitation test in acute dacryocystitis, okay? And if the condition is not treated promptly and timely, there will be the abscess formation. Abscess formation can happen in the region of the lacrimal sac. Fistula can form. The abscess can rupture this and it can comes out. The pus can comes out outside of the lacrimal sac. It is called fistula formation. So this can there can be the formation of abscess, fistula, and there it can lead to pre-septal cellulitis. Treatment can be medical and surgical. As like in the acute canaliculitis, we can advise the patient, we can prescribe antibiotics, systemic antibiotics and topical antibiotics as it is the infection. We can prescribe the patient analgesic as it is the acute inflammation and there is tenderness, pain, so analgesics can be provided. And warm compression, it can, like in acute canaliculitis, in the dacryocystitis, it can provide a soothing effect to the patient and it can also enhance the resolution of inflammation. The surgical options, there are, if there is the permission of abscess, then we can incise and drain the abscess. Okay, we can incise and drain the abscess. Now DCR. How can we perform DCR in acute dacryocystitis? This is because when the inflammation has resolved, there is nothing left. The acute dacryocystitis has been resolved and there is nothing. But still there is, the patient eyes are watery and there is excessive tearing from the patient eyes. So in that case, we will perform DCR. If the inflammation has been resolved and still patient present with watering eyes. Now chronic dacryocystitis. Chronic dacryocystitis, like the acute dacryocystitis, it is the inflammation of the lacrimal sac, but it is the chronic inflammation. Okay, so why chronic dacryocystitis develops? This is because when there is the impaired outflow, if there is some obstruction, or if the nasolacrimal duct or if the lacrimal sac, they have been narrowed. Okay, so if they have been narrowed, so there will be the impaired outflow of the tears. When the outflow is impaired, then there will be the accumulation of the secretion of the tears. So it can, the bacteria can invade the region. Because of the stasis, the bacteria will colonize and it can cause the dacryocystitis, which will be a chronic type. Okay, so because of the stasis, the bacteria will invade the region, it will colonize the region and it will cause a chronic dacryocystitis. Pathogenesis this is the pathogenesis. Sign and symptoms, this is more common from the acute type. Okay, so from the acute dacryocystitis, it is more common. The patient will mostly present with watering eyes. If this region can be, there will be a swelling or redness. This can happen. The swelling, redness, edema can happen in this medial lower canthal region. But remember, a patient with the chronic dacryocystitis mostly present with watering eyes. So the patient will present with watering eyes. And there may be, I told you that there may be a swelling in the canthal region. Okay. If we perform regurgitation test, if we press on the lacrimal sac, so the pus and the debris and the discharge will come out through the punctal region. This is called regurgitation test, and this is positive in chronic dacryocystitis. And I warned you that this regurgitation test we will not perform in the acute dacryocystitis because of the tenderness, pain. We cannot perform this. If we perform in the acute, it will worsen the condition of the patient. So it can be performed only in the chronic dacryocystitis. In other conditions like in the NLD, nasolacrimal duct obstruction, to confirm the condition. The treatment for the chronic dacryocystitis is mainly DCR, dacryocystostomy. I told you the dacryocystostomy is the making of incision in the lateral nasal wall in order to make a passageway and bypass this obstruction, and then the secretion will come out through the nose and in this way through the inferior meatus of the nose. This is called DCR. The last disease of the drainage system is the watering eye. What is the watering eye? If there is excessive tearing from the eye, this is called the watering eye. Okay? So, watering eye can be lacrimation or it can be epiphora. We have two types, lacrimation or epiphora. So, what is the difference between lacrimation and epiphora? The lacrimation is when there is the excessive tear production. This is called lacrimation. And epiphora, as we will discuss nextly, the epiphora is because of the drainage system is not working. So when there is problem with the drainage system, this is called epiphora, which causes the excessive tearing. And if there is the increased production, this is called lacrimation. Okay. So what causes the lacrimation? For example, foreign body in the cornea or conjunctiva, conjunctivitis, keratitis, inflammation of the cornea, keratitis. Okay. Iridocyclitis, inflammation of the iris and ciliary body, okay, and abnormal regeneration of seventh nerve. If the seventh nerve is damaged, is injured, and if it is regenerated abnormally, then with eating, for example, if someone is swallowing or eating, so there will be the tear will comes out of the eye. With eating, there will also be the production of tears. This is called crocodile tears, and it is happening in abnormal regeneration of seventh nerve. Lacrimation can also happen in hyperthyroidism. Okay, cholinergic stimulation can also cause the lacrimation. As lacrimation is the increased production of tears. So if there is the excessive cholinergic stimulation, it will induce the lacrimal gland to produce excessive tear. Okay, and psych stimulation. Psych stimulation, if someone is happy or if he is sad, then this can also stimulate the main lacrimal gland to produce tear. So these are the causes of the lacrimation. Now epiphora. Epiphora is, as I told you before, if there is any problem with the drainage system which cannot drain the tears, so the tears will accumulate in the eye, and it is called, and it will cause watering eye. So what are the causes of epiphora? Why the epiphora develops? This is because it can be due to obstructive epiphora or due to lacrimal pump failure. In obstructive epiphora, for example, if there is any obstruction in the punctum, if there is obstruction in the punctum, there is obstruction in the canaliculi, okay. If there is obstruction in the sac, if there is infection in the sac, obstruction in the sac, if there is obstruction in the nasolacrimal duct, as we discussed in the congenital and acquired nasolacrimal duct obstruction. So these all can cause epiphora. Infection, if there is infection anywhere in the drainage system, it can cause epiphora. If there is a growth, if there is some growth in this drainage system, if there is nasal polyp, for example, if there is the nasal polyp through the inferior meatus will block or will grow toward the duct and will block the duct. So these all obstruction in anywhere in the region, infection, growth, nasal polyp, this all comes under the obstructive epiphora. And if there is problem with the lacrimal pump, then if there is, for example, if there is nothing wrong with the drainage system. The drainage system is patent, it is open, but there is problem with the lacrimal pump. In what will happen? For example, if there is problem with the lower lid, and if there is the lower lid laxity, if there is the facial nerve paralysis, so due to the facial nerve palsy, the apicularis muscle will not function properly, and it will the eyelid will drops downward, which is ectropion. So ectropion, due to the facial nerve palsy, ectropion can develop. Ectropion alone can develop due to other reasons. So due to the lower lid laxity, the facial nerve palsy, the ectropion, this lower lid will comes downward, and when the punctum comes downward, so there will be nothing left for the tears to be drained, because the lacrimal pump comes downward to the abnormal position and the tears are accumulating in the eye, but there is no passageway for the tears, in order to go, in order to drains from the eye. This comes under the lacrimal pump failure, and it can be caused by these lower lid laxity, facial nerve palsy, or ectropia.